This is Julia. Just want to say a few words about her before introducing our speaker today. Julia Berg was a complex, courageous, smart, and challenging young woman. She was going to be a sophomore in the International Baccalaureate program at Southwest High School in the fall of 2005. Julia loved her friends, movies, roller coasters, and world travel. She loved the music of Modest Mouse, The Flaming Lips, Coldplay, and the Beatles. She was a swimmer, an actor in the summer theater program E3, and a budding social activist. Her passions were social justice, GLBT issues, and the environment. She had recently completed an internship with the local Sierra Club doing grassroots organizing and issue research. She spoke of taking her activism to new levels in the year ahead. Julia died in August that summer in 2005. She was hospitalized for a presumed gallbladder infection. 6 days later, she was gone. Those who treated Julia and those who have reviewed her death agree on at least one thing, that the system let her down. Julia's parents, Dan Berg and Welcome Jurdy, created the Julia Berg Memorial Lecture. It's a fund at the Minnesota Medical Foundation, and this is one way to keep the issue of patient safety, especially for children, in the forefront of medical education. Julia's parents, Welcome Jurdy and Dan Berg, are here today, and I'd like you to join me in thanking them for their generous gift in support of medical education and patient safety. I'm pleased to welcome Dr. Paul Sharek to deliver the third annual Julia Berg Memorial Lecture here at Pediatric Grand Rounds at the University of Minnesota. Dr. Sharek is an associate professor of pediatrics at the Stanford University School of Medicine. He's the medical director of the Center for Quality and Clinical Effectiveness at the Lucile Packard Children's Hospital, where he's also the chief clinical patient safety officer. Dr. Sharek received his education at Pomona College, the College of Physicians and Surgeons at Columbia University, and then his internship, residency, and chief residency in pediatrics at the University of California, San Francisco. He has an MPH from Berkeley and did a postdoctoral fellowship in healthcare outcomes and quality improvement at Stanford. In addition to his appointment at Stanford, he's a faculty member at the Institute for Healthcare Improvement and an associate faculty member at the Stanford University Center for Health Policy and Center for Primary Care and Outcomes Research. He's a member of the Pediatric International Patient Safety and Quality Collaborative. Dr. Sharek has received numerous teaching awards and has served on many national and international committees that address patient safety, and I'm delighted to welcome him here today to talk to us about his work. Paul?
Oh, thanks, John, very much. I wish my kids could hear that introduction. It would make them, maybe it would make them listen to me a little bit more. Thank you for the invitation. A deep honor and a real pleasure to be able to discuss with you some opportunities, I think, for improving the environment and the healthcare provision, the opportunities to improve that as a result of sort of a study of patient safety and a learnings from unfortunately, cases like yours. So welcome, and Dan, thank you so much for your gracious hospitality and the invitation. It's a real honor. Let's see, I'll put this down here. So I just want to give you a sense, for those of you who haven't been to Packard Children's or seen it, this is where I work, what it looks like. It was actually architected, I think, to look like sandcastles, from what I understand. But this was a picture, a very cold day in winter at Stanford. Just wanted to give you a sense of the challenges we live with in December. It was brutally cold that day. You see the palm trees were actually even struggling. And, of course, this is where we're located, for those of you who don't travel to that area. The home of many great things, the beaches, the wine country, and lots of sun. So I always like to point that out when I come to the Midwest. Formerly the home of the Governator. It was a long stretch for him. And he pretty much left our state looking like that, unfortunately. So this is where I come from. So anyways, thanks again. It's been a marvelous couple days. John, great host. Appreciate that very much. I spent the last day, at least day and a half, kind of learning about the organization, meeting with a lot of folks here. Oh, by the way, do we have some administrators in the audience today? I'd love to see. Oh, yes. Good. Very good. That's nice to see. So let's talk about what we want to dialogue about today. And I would love this to be a dialogue. There are a lot of data in here. There are a lot of suggestions, ideas. And although I've been brought in to speak as an expert about this, by no means are we perfect where I come from by any stretch. We suffer from many of the same things that this organization does in terms of our safety risks, et cetera. So I always see this as a bilateral info exchange, and let's make it that way. I really appreciate that. So stop me at any time if something catches your attention. I would much rather this be sort of a two-way discussion. But here's what I think we'll want to get through today in the next 45 minutes or so before the question and answer section. We'll spend a little time level setting. I just want to make sure everybody recognizes why patient safety continues to be on the forefront of everybody's consciousness now. The data are overwhelmingly compelling that this is an issue that's not going away for us. And I want to talk a little bit about some new ideas that I think, and that folks who do patient safety kind of from a practical as well as research perspective think will move us to the next level of our outcomes. And then, really crucial to the discussion today, and what I'd like to spend probably at least half the day talking about, the hour talking about, is how can families help partner with that? How can we engage families in such a way that they're true partners in terms of enhancing quality and safety? I think there's some great opportunities for that a few sites have really done well. So the take-home messages from today, you'll see these data. Harm occurs incredibly high frequency at children's hospitals. It happens here, I guarantee you. I don't know if you know your numbers, but it does. It happens where I come from. Maybe we're a little better than the average bear, but we're still orders of magnitude away from where we want to be. And so with that in mind, despite the efforts we have made to improve, it's clear that the paradigm in which we work is not going to get us to the next level. I think that's very clear, and we'll show some data that suggests that. So what I'm going to propose is that using some what are called high reliability concepts from other industries I think will move healthcare to that next level. I'm convinced of that, as are several folks in my space, so to speak. And that parents and families are crucial partners in that transformation as we move forward. So these are kind of the basics, what we want to get across today. Okay? So I have to show a disclosure slide. I'll just basically be quick. But basically, I'm a consultant for no one, unfortunately, et cetera, et cetera. So honorary from no one rich, unfortunately, et cetera. So bottom line is I have no financial relationships to disclose. I wish I did, but I do not. I'm not going to talk about any off-label stuff, et cetera. So we'll get through that. So why should we care about this stuff? Here's the level setting. I'll try to be quick with this so we can get to the dialogue. How many of you are familiar with the To Err is Human report? It's good. So when that came out in December of 1999, or November, depending on what citation you look at, it's interesting. That group distilled information from a lot of disparate sort of studies that had occurred over a 20-year time frame, and distilled that information, it's a very long report, but into a very few significant sound bites. And the one that catches people's attention, you'll actually see it's slightly different numbers, but between 44,000 and 98,000 deaths occurred in United States hospitals as a result of error. That was distilled from this entire report and became the message. There are other figures that show 120, et cetera. So I give you a sense of the scope of the prediction of those events. Now, it's interesting, medication safety has caught a lot of attention from a regulatory perspective as well as, I think, from most hospitals. An important component of deaths from adverse drug events, but it's a relatively small subset. And I think that the recognition of that will help us understand why we haven't made much of an impact yet. Compare that to, as just an example that they used in the report, 45,000 deaths per year as a result of automobile accidents. In thinking about the regulations and the safety initiatives that have been infused through that industry for a long time, gives you a sense of the magnitude. It's also very costly. So in terms of length of stay, we know that when an adverse event occurs, the length of stay does consistently lengthen. Malpractice stuff, obviously, a big issue when it talks about harm. A major credibility hit for us in the healthcare world has been that these events become more and more transparent. And we're losing our customers' faith, and for good reason, I think. So it's a credibility issue that we need to address head on. The Joint Commission, which is our regulatory body, over half now of the something like 1,900 metrics they require you to to collect and display are directly or indirectly related to patient safety. From a regulatory perspective, this has become dominant. Our systems in which we work are becoming increasingly complex. So just thinking about, just as an example, with our residency hour changes and the number of handoffs that occur as a result of that, it's just a small example of the complexity in which we work is accelerating. So one would envision that safety risks become more and more of a challenge in that environment, and that's absolutely true. And this is definitely not the flavor of the month. I recall when this first came out, people were like, oh, this will come and go. It's the next fad. It was not the next fad, and we've learned that over the last 10 years. So let me just make sure we're talking the same language so we can, again, level set. Is when I talk about an adverse event, we're talking about a harmful event, an injury, as the Institute for Healthcare Improvement states it, large or small, caused by the use or non-use of a drug, a technique, a procedure, et cetera, can be as harmless as a drug rash that comes and goes, or it can be as significant as a patient death. So when I talk about an adverse event, that's what I'm talking about. And it's important to also think about we interchangeably use the words harm and error, and it's important to make that distinction. And there are many reasons for that, but kind of the bottom line is that there's this massive sphere of errors that we make on a daily basis, and that's a result of being human. I mean, I can't remember the number. Something like 3% of all the decisions we make will be erroneous in some fashion as a result of the limitations of our own brains, right? Most of those, depending on where you look, don't fortunately lead to a true harmful outcome. Although it depends on how you look. This intersection can be bigger or smaller, and we'll see some data to support that in a minute. But that it can be a cause of harm, but a lot of times is not. So we have to think about when we're addressing patient safety, where is our focus? Are we thinking about eliminating all error, a very challenging situation for us as humans, right? Are we focusing on eliminating harm or the intersection of that, et cetera? So there are differences in the terminology I want you to think about as we talk about possible solutions. I cut and paste this study only because it was the study from which a lot of that Institute of Medicine report data was translated, and that's the Harvard Medical Practice Study, very famous, published in the New England Journal in 1991, and actually using some very crude, rudimentary sort of techniques to identify harm. They found in adult hospitals, about 3.7% of all admissions had a harmful event. Now, when this was published, it met with virtually a collective yawn. There was just really not much fanfare with that in the early 90s. It really wasn't until the Institute of Medicine sort of translated that it became a very influential piece of work. Some famous folks helped create that, including folks you might have heard of, Lucile, a pediatric surgeon out of Harvard, Boston Children's, Troy Brennan, a famous patient safety person, et cetera, et cetera. So keep that number in mind, and I'm going to quickly sort of show you over the last 10 to 15 years what the literature is telling us. And the bottom line is that number is dramatically underestimated, dramatically. So anyways, 3.7%. So in the early part of my sort of patient safety career, I helped try to establish what the epidemiology of harm is in pediatrics. So we first built what's called a trigger tool. We can talk about that if you want to, but a more systematic, invalid way, essentially, of identifying harm, retrospectively looking through charts. And for example, a trigger would be the use of Narcan. So if Narcan naloxone is utilized, it's an antidote to an opiate, potentially overdose. So if you see that, look back there in the chart to see if something really did happen as a harmful event. Well, anyways, so when we built that tool and then we tested it across 14 children's hospitals across, was it North America or the US? I'm trying to remember if we had some Toronto. Anyways, we found about 11% of our admissions, roughly, had a drug-related adverse event. So in other words, harm related to a drug we provided. So that's already fourfold higher, more or less, sorry about the math, maybe threefold, than what they had showed in the Harvard Medical Practice Study 15 years earlier. But the Harvard Medical Practice Study also looked at all harm, not just drug-related, which we have learned is a small subset. So we're starting to see orders of magnitude higher harm when we look at it in a more sophisticated fashion. We then looked at our neonatal intensive care units. I think it was across 14 NICUs across North America. And the numbers we were seeing were stunning. This actually got a lot of press when it came out. This was 74 harmful events for every 100 admissions. So you're almost at a one-to-one risk, so to speak, if you're born into a NICU, is to have a harmful event as a result of the care, something you weren't looking as a result, right? These are big numbers, and over half of them were perceived to be preventable. This is getting to be disturbing. And basically, these data were sort of the first snapshot in pediatrics of a very significant issue. And we then replicated that in the pediatric ICU setting. So the last was NICU. And again, what we found was even another notch higher. So basically, on average, about 2 harmful events per admission in peds ICUs. And this was a select set of very academic peds ICUs. These are peds ICUs that all of you would know and trust. So boy, if that's happening there, very, very concerning information. So the bottom line is that we have very strong information that suggests that harm occurs on a regular basis within children's hospital settings. Okay, so that's kind of the message here. And the conclusion simply stated are, oh boy, this is not good. We have a problem. Minnesota, we have a problem. I have a few Brett Favre references here along the way just to poke the audience a little bit. So how did we address this? Well, as I mentioned, the regulators jumped in right away when they saw these data, the Institute of Medicine report, and immediately Joint Commission and our state, your state is very aggressive in this, I know, started defining sort of what needs to be reported, what the fines might be, what the action plan should look like, et cetera, et cetera. And the regulators really helped drive this. And the way that we responded, I think appropriately so, is like, wow, we've got this massive problem. How do we address this? So, it's a logical approach. You look at what the biggest offenders are and you start working on those. Infections, narcotic-related medications, et cetera, and pediatrics, a big one, sedative. But what we're learning, unfortunately, I think, is that the results of this work, where we've targeted this and we've invested countless billions of dollars in attempts to fix this in pediatrics and adult medicine, have been unimpressive. So 5 years after that Institute of Medicine report came out, Don Berwick and Lucien Leap wrote a commentary in JAMA that said, how are things going after this report? You know, we pledged to do better, and the bottom line was there's some great efforts going on, but it's not affecting our national data at all, basically. Very sobering report 5 years later. So 10 years later, at the 10-year mark, which is a couple of years ago now, Don Berwick actually invited myself and a pediatric physician named Chris Landergan out of Boston Children's, a patient safety guy too, to help in an independent fashion construct the measurement strategy for harm over time to really have a better sense data-wise whether we've made a difference or not over the last 10 years. So this was in response to the 100,000 Lives campaign. Show of hands, people know that one? Institute for Healthcare Improvement. So their next generation campaign was a 5 million lives campaign, a little less publicly known, but it focused on harm, not just death. So they wanted to measure it because they did a poor job of measuring the results of their 100,000 Lives campaign and got blasted for that. So they asked for some independent folks to come in and figure out how to do it. So we did that. And I guess the good news from our perspective in terms of a research and a career move is, wow, New England Journal published article, front page of the New York Times. Very cool. Unfortunately for us and Don and everybody else at the IHI is we looked at North Carolina hospitals just for various reasons in adult medicine, and we found harms remain common with little evidence of improvement. So that's 10 years later. Think of all the things you guys have been doing to try to address safety. Here are the data graphed out. And that is, these are all harms over time on a quarterly basis for the 6 or 7 years that we looked at across that state. No trend downward. So we thought, well, let's look at the preventable ones at least. And that is subjective to a certain degree, is, they were allowed to define what they thought was preventable or not. No difference there either. Now, these are... So Don Berwick tells me, Paul, thanks for doing this, but you've just shown that we haven't done squat over the last 10 years. Thank you very much. But these data, I think, are realistic, and I suspect probably if you guys thought about this from a personal perspective, you'd probably come to realize that we probably haven't made the dent in the patient safety world that we really want to. Thoughts, comments? I saw a hand.
Well, I was just thinking, if I see this much around the fourth quarter, I was just wondering
Yes. Yeah. There are some data that suggest that. This study included hospitals that were both sort of resident, that had an academic mission as well as non. So we did not interpret it that way. We didn't see any statistical trending in terms of particular time periods. But it's a great question, and there is some evidence out there that suggests maybe that is an issue.
Along the same lines, if you put an arrow when the residency hour would change,
Yeah.
where would that fall?
I don't know. Didn't look at that. It's a good question. I have to remember exactly the hospitals we randomly selected. I think only a small percentage of them, a proportionally appropriate collection of them had residency and academic backgrounds, but most of them were not. So I'm not sure. That's a great question. So, all right, so we talked about this a little earlier. It's like, okay, we've done all this great work. We've really focused on the high-ticket items. There's been legitimate and consistent efforts to improve this, and we're still not seeing any difference. The data is really clear that we haven't made much of a dent. We're getting to this level of reliability, and I'll show you what I mean by that in a second. That's mediocre. I mean, this is orders of magnitude worse than industries that have looked at safety for many generations. And we'll talk about that in a second. So what I'm going to suggest to you, and most people now in my shoes in terms of patient safety research have decided, you know what, the paradigm in which we work in now is, boy, we can work harder and try harder. It ain't working. So we've got to think about a different way to approach this. And so that's when folks like myself started looking outside of healthcare to learn from other industries that have done a better job of this. Now, I've had a number of audits, and I totally understand this. I'll have folks say, if I hear the comparison to healthcare to the nuclear power industry one more time, I'm going to vomit. And I understand that. There are different sort of challenges and levels of complexity in those different industries, so to speak. But that doesn't suggest to me, at least, that we should not learn from what they've done well. So let's think about that and talk about that and how that would look in healthcare. So when we talk about those types of industries, and I'll show a graph in a second that sort of categorizes those, we talk about reliability. So you'll see these things called reliability index, or sort of what it means to be highly reliable. And when we talk about high reliability, we talk about failure in 1 or less times out of 1 million opportunities. So let me give you an example. So let us suppose that I have a very active practice where I, for whatever reasons, had to give 1 million doses of morphine to my patients. If I had a highly reliable system in which I infused that morphine, I would have 1 or less failures as a result of how that system was built. Can you imagine that? I mean, it's hard to envision in the world we live in. That's what we're talking about, though. So what can we learn from other industries that have done this well? Well, here they are to start off with. This was in a paper about 6 years old now that looked at René Amelbert is a French MD PhD who does a lot of organizational psychology stuff, et cetera, and partnered with Don Berwick and others to try to explore these other industries and at least categorize them based on the data that we know. And what they found was the French railways, not sure if it really is true, but the French guys said the French railways were great. But commercial jet aviation, nuclear power industry, these are where the comparisons start to come from, or these types of data, right? This has been a very influential paper in my world because it's really laid out pretty clearly where we stand compared to other industries that can be very unsafe, that are very risky at least. So here's where we lie as an industry overall, medical risk. Now, there are components of our work that are more unsafe, and understandably so. A higher risk cardiac patient, example, is going to be, by their nature, likely to be a little bit less likely to have a great outcome. But what I want to point your attention to, and this is where, I have some skeptics always in the audience and say, there's no way healthcare will ever get over this direction. We're just different. And what I would say to you is that anesthesia, although in low-risk patients, ASA level 1, that's a low-risk patient, they've thought about this. They've been on the forefront of safety well before the rest of us in this room. And they figured this out. They now have, at least for low-risk patients, they are in the high reliability sort of category. Incredible. A beacon of hope for us, I think, in healthcare, as well as transfusion medicine. So unless you come from Duke, you pretty much have not seen a transfusion issue that caused death anyhow, at least as far as I know. There are very few that happen in the United States anymore. And this is a result of a clear focus on eliminating that as a possibility. So we have some opportunities to learn from our own folks as well, right? So in essence, what we're trying to do is this. We're trying to move from mediocrity to greatness. I knew that would get it. Or if you're a different sport, how about this, right? So the way that folks in my world are starting to think about that, and this has been a marvelous addition to our literature, has been the work of some folks out of University of Michigan, another Big Ten area. So hopefully you see that as non-competitive. But it's a guy named Carl Week. I've never met the gentleman, but I think that's how it's pronounced. And he and his group, he's an organizational psychologist, I believe. Not a psychiatrist, I think he's a psychologist. And he has said, and his group is like, wow, look at all these other industries. They do a lot of things right. What is it about each of these very different industries that they do all the same, that ends up in that spot? Sort of almost a case control sort of study phenomenon. And what they found out, they distilled it down to 5 things. Now, that every one of those industries that I pointed out does consistently well. Now, so our job, then, if you believe this, is how do we translate this to healthcare? This is really tough stuff, but at least now we have a roadmap, at least a little bit of one. So let's go. We'll go through this in more detail in a little bit, but what I want to really delve into pretty quickly now is how can families fit into this? How do they help move us to a more reliable state? And one could envision that there's immense opportunity there. But let's talk about these here for a second. Preoccupation with failure. I'll describe that more, but that is that essentially when an inevitable failure occurs, do we utilize that as a genuine opportunity to improve, or do we push it under the rug, or do we say, oh, this happens all the time, this is just the way we do business? I mean, there's a whole host of ways you can react to a failure, but industries that do this well say this is an opportunity for us to learn to improve our system. Reluctance to simplify, we'll talk about that more in detail, but the bottom line is that I, as a physician, if I write an order that's a 10-fold overdose for, say, a narcotic that causes cardiorespiratory arrest, well, it'd be easy for you guys to say, oh, that physician is a moron, should be kicked out of the profession. Those industries that think deeper about this would say, well, what was the context in which that doctor wrote that order? Were they up all night? Did they have too many patients they were taking care of? Did they get a handoff that was good or not about the patient they wrote that order on, et cetera, right? So that's context, right? That's reluctance to simplify by saying, moron doctor, kick him out. That doesn't fix the system at all. So these are what these industries think about. Sensitivity to operations, so recognizing and understanding at the point of care when risk is occurring. So for example, you have 20 patients on your service and 15 of them are decompensating or getting worse, right? So if you're sensitive to that issue, you know bad things are going to happen. If you're picking up on that, if you have the cues to suggest that things are changing, this is has some military application. You hear about it as situational awareness. We'll talk about that. Commitment to resilience. So when an event inevitably occurs, how do you respond to that? We talked about preoccupation with failure. You focus on it. But you have ways of recognizing when something is changing for the worse and mitigating that before it gets worse. And then deference to expertise. So who are the decision makers in the industry, the organization? Are they senior executives, for example, that aren't really embedded at the point of care, that may not really understand exactly what's going on at that given time? Are they making decisions that could affect the outcomes? We'll talk about that too. But these are the ideas that have emerged from these high reliability industries that now it's our job to figure out how to translate them. And Week and his group come up with this sort of summation, which I think is brilliant, and it's very understandable. So together, these 5 processes that we just talked about produce this collective state of mindfulness. All right. So to be mindful is have an enhanced ability to discover and correct errors that could escalate into a crisis. So, continuing with sort of a sports analogy, I've always been a big Peyton Manning fan, and one of the things that I find so compelling about the way he conducts his business is that He is very mindful of what's going on. So, for example, he gets the play called in from sort of the seniors, right, that think they've got the right plan for that given call. And he walks up to the line, tells his, in the huddle, he tells what's going on. He walks up to the line and he surveys what's going on. And he sees, they're in a cover 2 coverage rather than, I don't know, whatever, a 4-3 or whatever the other coverages are. This play may not work in this scenario. It was a great call, but not for this circumstance. Situational awareness, right? He is now empowered, right, as a leader to change that play, right? So he is the one that ultimately makes that decision whether that play is going to work or not, et cetera, et cetera. So this is actually a really interesting, I find this a really compelling sort of sports, and you can think of your own sports analogy or any analogy outside of healthcare. But a lot of these high reliability concepts are embedded in that example. It's kind of interesting. So that same paper that I cited, that graphic, with the circles and the industries and stuff, they sort of translated this concept and distilled it down into a conclusion that was this concept of collective mindfulness, which we just talked about, this sort of the accumulation of all those 5 components. Really challenging in healthcare for many reasons, but probably the most important difference between all those industries that they looked at was in their willingness to abandon historical and cultural precedent linked to autonomy, right, in a constant drive towards a culture of safety. So this is a cultural phenomenon for us, isn't it? Is that we live in an environment and we are trained as physicians that we are ultimately accountable and responsible for that patient's outcome. Right? That's how we're trained. That's how the malpractice insurance industry works. That's how peer review works, right? Is that I'm responsible. So those who are collectively mindful would start to realize that, I may be the cardiothoracic surgeon, but you know what? The nurse that's helping to take care of this patient, the cardiologist that's helping me in the ICU setting, the respiratory therapist that's helping with the ventilator, all of us together are collectively create the outcome in which this happens, not just me. And that's a big, big cultural shift for healthcare, right? So what I've done, I'll try to breeze through this very quickly because I've tried to distill down those ideas into some practical, albeit not easy, but practical ways and tangible ways of transitioning healthcare a little bit more to becoming highly reliable. Now we're going to start to talk about the families. But so leadership. Patient-first mantra, organizational clarity. What does your mission statement say about who you are? You guys, who knows the mission statement for the Children's Hospital here? Oh, yeah, good, that's good. See a couple of our administrative leaders, that's great. Well, here it is. I went online and just checked it out. I wanted to see what it was that you guys were all about. And they actually call it a purpose, although they have it as their mission on the title, so I assume that's what was meant. To bring hope and healing to children and families we serve by caring for one child at a time while advancing education, research, and care on behalf of all children. What I like about this is that it places the outcome first, the child's health care outcome first, with an important and supportive education and research agenda. That's marvelous, actually. That's really impressive. And I would suggest that there are many academic and children's hospitals that don't have it in that order. Our mission statement, for example, I'm embarrassed to say, at Packard Children's, does not include at the forefront that we are focusing on the best outcomes we can. And I've worked with our board for many years, and our board of directors said, that's assumed, Paul, we're Stanford. Like, that shouldn't be assumed because the message is not clear throughout the organization. So anyway, the beliefs, what they listed right underneath is that the child, amongst other things, the child and family are the drivers of decision making. That is phenomenal, and that's going to be what we talk about for the next several minutes. Let me go back here and wrap this piece up, and then we'll get to work here in terms of family integration. But human factors. So how do we deal with things like how the humans interface with the environment? Are we cognizant of how fatigue affects performance? Are we aware of appropriate staffing ratios, for example, et cetera, et cetera? What's our culture like here? I've learned a lot about your culture. I'm probably only getting a sniff, but some interesting cultural findings, certainly for the organization, I've found even over the last 36 hours that I think directly impact how your outcomes and how safety is viewed. How transparent are you about both good and bad outcomes? What is your data like? How many of you know, let me just, I don't know, your adverse drug event rates? Just your harm rates due to medications. I know you do. That's good. How many of the docs in the room know that data? Okay. How many docs in the room know your observed to adjusted mortality ratios? Do you? Sort of? Okay. All right. That's good. How many know your catheter-associated bloodstream infection rates? Okay, so a little bit, so that's good. So you get the idea is that, so in order to improve, one has to know what your data is telling you, right? And transparency is a big piece of that. The ability to simulate sort of rare but high-risk situations, certainly very prevalent in other industries that do this well. Zero defect philosophy, this is a good one. So do we walk around in this organization thinking that, for example, ventilator-associated pneumonias are probably inevitable if you're intubated and you're in the ICU long enough? Maybe not. There's starting to be a transition towards anticipating that zero is where we want to be. Everybody would agree that zero is where we want to be. But do people believe that zero is where you can get? I remember working 5 years ago, even at Packard, where we thought, oh, our children are sicker than everybody. You know the story, right? They're in the ICU. They have lines in. They're going to get an infection every once in a while. They're immunocompromised. It's just what's going to happen. And up until the last 3 or 4 years, we just assumed that there was a certain baseline level of catheter-associated bloodstream infections that kids would get. So that's not a zero defect philosophy, right? So industries that do this well believe this. Stop the line. Do you have culturally the opportunity, if you see something going wrong, that you can stop? This comes directly from like the auto industry, for example. That we can stop that process, time out before we do anything more. For example, are the nurses empowered here as an organization? If you see a surgeon not wash his or her hands and check a wound, can the nurses say, hold on, can't touch that wound until you wash your hands? What do you think? Yeah, a little bit. That's good, if that's true. That's not easy. But anyways, so that's not only the opportunity, but actually the accountability for doing so. Yes, sir?
Do the parents have that responsibility?
Well, we're going to talk about that. Now, we are starting to do that. So actually, I'll give an example in a minute where we have actually asked if the parents and families are interested in this, and it's a challenging ask. But in our cardiovascular ICU, where they have like often 6, 7, 8 lines at a time, we ask them to just help us with this line care. Could you please tell us if we haven't scrubbed the hub for 15 seconds? We'll ask that. And we'll ask the family if they're comfortable doing that. And most of them are like, yeah, I can help with that. I know exactly when you guys sort of bypass that important step. So it's interesting because that culturally is very challenging for the nurse, for example, to hear, or the doc. But that's the type of thing that we're moving towards. And a highly reliable organization who's collectively mindful would require that, right? Would encourage that. So we'll talk about that more in a bit as well. Systems thinking, I think you guys are pretty good with this as far as I can tell, but that the concept that the outcomes of which you are eventually achieve are not so much the results of individual care, but the system in which that individual practices, right? Standardization, a challenging concept for us in healthcare, of course, that our decisions are driven by data. Some real opportunities, I think, with your new EMR, which we can talk about. A lot of frustration with that I've heard over the last 36 hours. And the use of technology to support these. So anyways, these are I think, tangible, albeit challenging, ways of addressing and enhancing our ability to become more highly reliable within the healthcare setting. So that's usually my sort of summation slide, but I wanted to use this as a kickoff to a discussion more about how families can get engaged. So let's talk about that. So when we talk about collective mindfulness, right, those 5 things that were distilled down, how can parents fit into that? Well, I think the answers are actually a little bit embedded in that mission statement that I just showed you of your children's hospital. It's pretty impressive that that is stated concretely. And that is that shared decision-making must be a required sort of component of the way we do business. And there's 2 ways well, there are many ways of doing that, but there are 2 areas I want to focus on. One is within the context of the specific healthcare team which is taking care of that particular child. Okay, so that's one way you can be integrated and collectively mindful and participate in that as parents and family members. But the other way is thinking about it more systemically. So infusing family ideas, leadership, et cetera, into the decisions that are made throughout the hospital setting. I know you all have a family advisory council or family centered care sort of group. I'm just curious to find out, how many of you interact on a routine basis with some of the family advisory members? So, okay, that's good. So you utilize some of that expertise to help drive your decisions. Let me keep going, but I'm going to ask you guys at some point to tell me how they're utilized here, from a systemic perspective, how are families' opinions infused into the operational decisions of the organization? It's interesting stuff. Okay, so let's talk a little bit about this. The Institute of Medicine, by the way, got this right. They followed up with their To Err is Human with a report 2 years later. They sort of defined the problem. 2 years later, in Crossing the Quality Chasm, which is another famous Institute of Medicine report, they kind of created the solution set for how we'd fix this. And they did many things really intriguing and valuable in that report, and one of which was they sat down and defined what they thought the components of quality really were. And what they said, furthermore, is that in addition to these 6 domains, they set up a hierarchy. They said if you do not have patient and family-centered care or evidence of safe care, you will never have the ability to be a high-quality place. These are at the core of a quality focus organization. So they got it right. They said the family and patient's experiences and voice is squarely in the middle of being a high quality place. That was really cool. And not too many people knew how to do it back then. This was in 2001. But anyways, they were onto something. So how do we better integrate parents in this shared decision making? Let's talk about structure a little bit. I'm going to show you the structure we have at Packard. We do this very well, I think. One of the reasons why I think John asked me to come out here is that we have some experience with this. By no means perfect. In fact, I should have prefaced all of this by saying, if I didn't, we've got plenty of problems at our organization too. As an expert coming in, it doesn't mean that we don't struggle with many of the same things you guys do. Maybe I've just had a chance to think about it more. I don't know. But anyway, so let's talk about a structure of a healthy family integration in the organization and just have you think about these things to see if they remotely map to what's going on here. And it's kind of a laundry list of things here, but I'll just go through a few of these. First of all, it turns out we actually have an endowed chair position for the person that directs our family-centered care group. Now that's pretty cool. I've heard of no other place that has that sort of thing. That's, I think, a very formal statement of the importance of this. We have about roughly 30 parents that are actually paid as mostly full-time employees of the hospital to help guide us with this work. Does anybody have any idea how many folks you have that might fall into that category? Is that a guesstimate?
Well, for the children's areas, we probably have about 22 parents that are
Okay.
that we utilize. There's an active group of about 12 to 15 who sit on our parent advisory
Yes.
board. And then we also have adult services advisory committee and
Yes.
behavioral services committee that crosses both child, adolescent, and adult behavioral services.
Good. Are these truly sort of trained and employed people of the organization?
Employed, they have to go through volunteer training
Yeah.
and be trained that way, but our philosophy at this point is for our board committees and others are non-paid.
Yeah, okay. So that's interesting. That speaks to some levels of commitment, I think, organizationally. Just as some examples, we have a ton of different sort of local family advisory groups. For example, sort of our neonatal intensive care unit has their own family advisory council that helps provide guidance, as well as some deeper things, which we'll talk about. We have some specific parent mentors that help patients through, say, transplant situations where they're paired one-to-one for families as they go through the transplant experience, as an example, or cardiothoracic surgery. We have a significant cadre of family actors within our simulation setting that allow us to simulate, for example, disclosure discussions. Very interesting stuff, et cetera, et cetera. There is a very robust infiltration and infusion of family experience, guidance, advice, recommendations throughout the organizational decisions. I'll just sort of leave it at that. And there are various levels of this, from sort of just advisory roles all the way up through truly partnering with hospital-wide decision-making, for example, with the hospital build. We have, as a co-chair, essentially one of our senior family advisory persons to really help guide those decisions. Okay. Deeply embedded within various aspects of our work. And I'm going to skip through that a little bit because I want to get to some of this other stuff. But how do we better integrate in terms of this collective mindfulness stuff? Well, the Joint Commission, we talked about the Institute of Medicine getting it. The Joint Commission actually gets us too, and one of their national safety goals has here is encourage patients' active involvement of their own care as a patient safety strategy. All right? So there is recognition that this is really crucial from external forces. So let's talk about, and I want to get to some discussion and questions, so I'll try to make this pretty quick. But let's talk about each of those 5 components that we talked about and how, as examples, how families can infuse their ideas and participate in this shared decision making. We talk about preoccupation with failure, worry about the normalization of unexpected events. So in other words, oh, this is the way things occur here. It's just part of the way we do business, so to speak. Here's some opportunities that we have found for families to really get engaged in this. This is one the Institute of Healthcare Improvement recommends that we don't use so much, but it does promote engagement, to say the least, is that the invitation of or participation of families at board-level committee meetings talking about what happened, what are the safety risks that they experienced as a family. I don't know what your thoughts would be, Welcome and Dan, as to whether you would feel comfortable or interested in talking to your board, the board of the hospital. It's a powerful thing. Anyways, it's an important engagement opportunity, for example. Having family representatives, i.e. Either the folks that we're involved with or at least that have some oversight and understanding of the systems that sit on and contribute to the committees where harmful events are discussed. So we have embedded a number of different family representatives within my patient safety committee structure and our quality oversight structure, all the way up through the board of directors with a family advisory member who is an active participant of our quality and safety board committee. Very rich interactions and influence that can occur as a result of that. Having families involved in root cause analysis, that is an interesting and challenging one. But if you want to have the entire picture of what happened in a given event, who better to help provide yet another different perspective than having the family member there to discuss during those closed-door sessions. This is pushing the envelope, isn't it? Something to think about. Families integrated in the simulation work. So, for example, having when we simulate sort of putting a child on ECMO or heart-lung bypass, we simulate that frequently. But sort of in an emergency situation, how the families interact with that or dealt with that, we simulate that type of work. We try to understand how the families can help support this and how we in turn can support them as these things are going on. And we simulate that because these events, fortunately, are not incredibly frequent anymore, thank goodness. But anyways, you get the idea. Families invited to participate in, we talked about the line entry thing that you just asked about, but there's some other examples that we utilize. For example, we have our kids that are on chemotherapy. We have family members writing down, checking against the protocol whether we're doing the right med at the right time. This is an example. And they'll literally look at the bag to see, is that the right concentration? Is that the right dosing, et cetera? And, if you're thinking about collective mindfulness, what a great partner, right? Who is more engaged in that right medicine going in than that family member?
Do you regularly request that, encourage that?
Yes.
Or
it depends. It depends on the family. We try to be comfortable. We try to be respectful of the family's wishes. Sometimes they feel that's a bit of a burden. It's too much of a burden to feel as though that some people perceive that as they're helping to be responsible for that, and that's hard to stomach for some folks. So we attempt to be, we invite them into that process. We don't do this for every patient on our floor, don't get me wrong, but these are opportunities to engage them, and it's worked very well for us. These are challenging things to do, though. Don't get me wrong. This is not easy stuff. When we talk about reluctance to simplify interpretations, we talked about an example of that, but how do we get families involved in that? So we talked a little bit about having family members actively participating on committees that create the systems in which we provide care. Let me think of an example of that. So in my patient safety committee, when we were first implementing our rapid response team work, we worked a lot with our family advisory members to determine whether they thought at that time that a family member should be allowed to call one of those rapid response teams. Now that's almost universally done, but this was many, many years ago. And the perception was, actually, as I suggested earlier, is that they didn't want to, at that moment, the perception was they didn't want to feel as though they had that responsibility, that if indeed something bad occurred, that they blew it by not calling, right? There's an interesting, I would have never thought that. I would have said, we should get the families involved right away. That actually, at that time, in terms of our organization's maturity, that wasn't where the parents wanted to go yet. So it's very interesting. So they directly told us how that system should work, and it really helped. So that's maybe an example of what I mean by that, but there are many, many others. This is one that I know you're starting to embark on, individually inviting and requiring, if they believe, if they're available and interested, to participate in rounds to provide a much deeper context to what's going on. So family-centered rounds. Do it? No? How much? Consistently? Does it work? Phil, you like it? Yeah. It's transformative, to say the least. And for those of you maybe who haven't experienced that, but to invite the family in to be a contributor to the information that's being discussed and to have them hear what we're thinking and what our decisions are based on, that thought processes, is really hard, but it's really important. And I can't tell you the number of times that we have learned about or heard about something that we had otherwise did not know. And that directly changed how we were going to approach our decision making for that day. So not much more specific you can get about shared decision making than for the families to participate in rounds and actively contribute to those decisions. John? No? So, okay. A provider commitment to listen to the entire story. Now, this one's a little bit more nebulous, but what I mean by that is that there are certain layers of information you get. And at some point, we're all busy people, and we struggle with hearing sort of that next level of information. I think committing to listen to families in totality is a bit of a challenge for us at times. We all know some families that will spend an hour describing how things are going, but a commitment to really listen to that, because you will find and you will hear, if your shared decision making is a philosophy, you will get something from that that very well could change how you approach how you can interpret a symptom. Not always, but a lot of times. And if you're committed to the concept, you got to go through that. Sensitivity to operations, situational awareness, being attentive to the front line. We talked a little bit yesterday with various groups I did about how you carry out quality and safety improvements. And the way we have chosen to do that, and we're still disseminating this, but is through what's called the microsystems philosophy, or the idea that there are multidisciplinary teams essentially on every unit that are in charge of, accountable for, the outcomes that occur on that unit. That's a very different perspective than somebody who's senior saying, okay, you need to fix this and report back that data to me, in a month. And we'll see how it's going. So embedding families in that decision-making process, looking at the local data, allowing them to provide guidance and recommendations as to what the next steps are about improving our handoffs. Should the families be involved in our handoffs between the OR to the ICU, et cetera, et cetera? And if so, what should their role be in that? Anyways, a commitment to embedding them informally into how you do quality and safety improvements on a regular basis are really impressive. An important step for those who are concerned and interested in shared decision making. I know you guys have local improvement opportunities. Do you consistently have families that contribute to that?
And we go through the myriad of discussions we've had across the organization around that and what we're continuing to push for. So it's probably more intermittent. So on the PICU innovation team, we have parents very engaged in that one.
Okay.
But from a regular membership standpoint on our interdisciplinary teams on a unit level,
Yeah.
not consistent.
There are very few, if any, other places that I know of in the United States that are doing this on a regular basis. And we've committed to that, in part because we have the resources to do so. We have a large cadre of well-trained families that are dedicated to this. Something to think about, anyhow. We talked about the stop-the-line opportunities. So if we're committed to everybody in the room at the time something may be happening, if a parent, for example, can blow the whistle and say, we'll talk about rapid responses again, right? I know that you guys expressed last evening that boy, I wish we had the opportunity to just say, where's the blood, right? And to call that somebody else in to take a fresh look. That's sort of an example of stopping the line, I think, is that things aren't going the way we think they should be. Do families have the opportunity and certainly the right to do this? That's high-level thinking right there. It's not easy to do. Parents involved with the handoff process. We're actually doing this now on a routine basis, nurse to nurse between shift-to-shift handoffs. The two nurses that are leaving and coming in front of the patient and the family are going through a checklist of things and informational exchange and having the family members listen in and correct, if necessary, what's going on. That is cool. It takes a lot of time, but it engages the family members in a way that allows them to comment, to correct, as well as to feel as though they're an active team member. Really important philosophical change for us there. So, sounds pretty interesting stuff. Yeah. We talked about family-centered rounds as well, which is crucial. Deference to expertise. I don't think I gave an example of this. One of the examples I often use is that we had, fortunately they were near-miss events, but we have some really poor pumps that were resulting in IV pumps that were resulting in erroneous programming on a regular basis. It was always caught, which we were lucky about. But we heard about that, and thanks to some really swift communication, we said, we got to really fix this. This is a classic human factors issue where the interface between what I'm thinking and what I'm dialing in just doesn't click, and mistakes are routinely made. So when we heard about that, we of course talked to some folks such as, say the pain management team, the folk that oversees, say, TPN administration, biomedical engineering for pump interfaces and stuff. And sort of the senior leaders came up with a recommended pump, it's a tangible example, that made sense from their perspective in terms of cost and our ability to interact with our electronic medical record, et cetera, et cetera. When we brought in that pump for a trial, and we asked the nurses who use the pump to say, oh, does this work for you? They said, this pump sucks. This is terrible. We're going to make mistakes on this constantly. We like this pump a lot better. So in an organization that is thoughtful about deferring to those that have the expertise, that organization picks the pumps where the nurses are more comfortable with. And we went that way, but I'll tell you, it was not without challenge. It shows how we as an organization struggle with these ideas too. But it was more costly. It didn't interface quite the way we wanted it to, but we could make it work. It was more challenging. But the folks who were at the sharp end of care, the experts in this work, made the call. It's an important component of a highly reliable place. So how can families get involved with this? Well, we all know that the ultimate expert of any given patient is the family members, by and large. There's so many different diseases of kids who walk in with specific diseases that are so rare that I will say, would you mind, essentially, let me learn from you family members about this illness because I've read about it, but I've never seen it. Guide me into what I need to do next, right? So integrating, that's, again, shared decision-making is an opportunity. We talked about that. Another example of, rather than, for example, our pain management service providing their orders and recommendations around pain control, we've sort of established the opportunity for family members based on their own child to pick what makes the most sense to them for any given procedure, IV placement, et cetera. That's actually been really a marvelous exercise in the sense that families are doing things very differently than we would have if we just sort of sat down and did it. So opportunities for deferring ultimately to those most expert in that particular patient. And finally, last but not least, I reversed the order in this for a specific reason, but commitment to resilience. So we talked again, so philosophically, something bad may have happened, but don't allow it to keep going, right? Systematically, having families participate in, after a root cause analysis, looking at action plans and determining, from my perspective, do those next set of actions make a lot of sense? Some of the things I bet you are most interested in learning about after your daughter's death was what changed so this can't be prevented again. To have access to that information and to comment on that and to learn about that from your perspective would be a massive attempt towards shared decision-making, wouldn't it? Oops. And
Can I just say that?
Please do, Dan.
Our experience in that regard was very good.
Great. That's great to hear. It shows a very sophisticated series of organizations in which you are working in. That is not the norm. So in terms of the commitment to resilience, last but not least, is I really point to you two. And thank you so much for what you have done, both locally and even nationally, for highlighting patient safety challenges and risks and opportunities for us all to learn within the context of system-wide change. And this is the perfect example to me of being committed to the topic and being resilient to when things occur, because they will. And so your dedication and time in reliving this on at least probably a daily basis, but formally on a yearly basis, going through this over again, but being committed to making the next generation of our work better as a result of what happened is the ultimate commitment to resilience in terms of my perspective. So I think with that slide is a good time for me to wrap up and leave this open to any other questions or comments that you all may have. So thank you very much for the invitation. It was indeed an honor, and I really appreciate the opportunity to work with you guys. So thank you.
Thanks, Paul. We have time for some questions. If anyone has a question or comment,
Well, thank you very much. This exciting approach is really revolutionary as a
Thank
parent
you.
and a nutrition.
Oh, thank you.
Say that. I have two questions which are kind of interrelated.
Okay.
When you think
Write 'em
about
down.
getting the story,
Yep.
do you think that the amount of time that is needed to be done what we do has actually impacted the care of our patients? And for example, one of our best residents who graduated a couple of years ago said, I think I spent 90% of the time
Yeah.
rather than, getting
With
the
the-
story from
yeah.
the patient. And then secondly, do you think it, over the last 20 years, another challenge which has adversely impacted patient care has been the challenge of working through an interpreter with families from many different cultures, again, trying to get
Yes.
the entire story. I see those as, especially our residents and as attendings too, those are challenges that I think sometimes interfere with getting the story.
Oh, indeed. Very, very true. The document, we'll start with the documentation issue. We spent a lot of time yesterday learning. I spent a lot of time yesterday learning and hearing about some of the challenges around the Epic EMR and how it feels as though you're in front of the computer constantly and less face time with the families. I know it feels that way, and I suspect that even certain ways of rolling that out would promote that. But I would suggest that at least over time, the data is reasonably clear that eventually when your processes are humming is that the computer, the EMR integration actually helps increase patient face time. And we've actually documented that, at least at Packard, over the last couple of years, is that nurses now, for example, are spending a significantly larger percentage of their time face-to-face with the families. So, yes, there are huge risks to that. Absolutely true. And by the way, I'm supposed to repeat this, I think. Is there any taping going on? Okay, good. Sorry. Yes, documentation is a challenge and certainly draws away from the opportunities to interface on a more regular basis with families and with other members of the healthcare team. However, I think a thoughtful implementation and sort of evolution of the electronic medical record should help you with that. I actually firmly believe that. I think there are ways of sort of pre-populating certain things or drawing other information so that you're spending less time doing that and more time doing what you like to do. And I can speak personally from experiences. The moment our electronic medical record allowed us to do sort of physician documentation, I probably saved an hour a day easily from my workload of writing notes to really teaching and spending more time with the families, et cetera. I've seen a very tangible improvement there. So I think there's some opportunity there.
Sometimes the ability to forward information.
Yes.
I think sometimes that is detrimental to our thinking about what is going on
Indeed.
today.
There are risks there, too. Absolutely. The other question was the interpreter question. And this is an important one here, I know, and as well as where I live. And as an example, with our family-centered rounds, we have a dedicated interpreter for every team. Now, that is a huge expense. There's no question about that. But here's the deal. If the organization is committed to the shared decision-making concept, and this is a crucial interface, you suck it up and you pour the resources in and you do it. Fortunately for us, and maybe for you guys as you sort of evolve in your family-centered care and your rounds, is that you will find that there's a lot of time savings opportunity with those single interactions rather than sort of fragmented discussions. We have shown, as an example, that the nurse now pages our physicians far less frequently to just sort of get updates on things or to get communication about, oh, what were you thinking with that order? Just as an example, there are measurable time improvements, for example, that do translate to returns on investment by being able to carry this out in an efficient way. So, yes, a challenge. Priorities.
In the interest of time, I'm going to end the discussion here. I'm going to invite you to approach the podium if you have other questions that you'd like to talk to Paul about. Paul, I want to thank you for
Oh, you're welcome. Thank you.
spending a couple of days with us once again, and I want to thank you for supporting this. I appreciate it.
Yeah, thank you guys very much.